to today's ECHO Clinic. Before getting started with introductions, we would like to share a general reminder to maintain confidentiality by not releasing any personal health information of the individuals being discussed today. Please mute yourself when not speaking by clicking on the microphone icon in the bottom left corner of your Zoom screen. Audio participants, please dial *6 to mute and *6 to unmute. Prior to speaking during this clinic, please introduce yourself by saying your name and location. This allows those who are using audio to follow conversation as they cannot see who is speaking. Thank you. I am Jasmine Azari from Neighborhood Health Centers, working with MAT and ECHO.
And for those of you who are new out there, welcome. And Star is reaching out to you to get your email contact information. So look at your chat if you haven't done that already. And we'll get started. We're a little crew today, but we are small but mighty. Okay, more introductions. Let's start with Emily. Emily, so if you can unmute yourself and introduce yourself.
So my name's Emily Santry, and I am a care manager here at Magellan in the Newtown office.
Great.
Welcome, Emily.
Thank you.
Maria. We can unmute Maria. All right, you're unmuted. Can you introduce yourself, please?
Yes, hello. My name is Maria LaMonica, and I'm a care worker here at Magellan Behavioral Health, and I am located in our Bethlehem office.
Oh, great. And Crystal?
Hi, I'm Crystal Rapoli. I'm a drug and alcohol care manager at Magellan.
Great. And are you in Newtown or Bethlehem or someplace else?
I work from home.
From home. Okay. Awesome. Hi, Cindy. You want to introduce yourself? You're unmuted, but we don't hear you. Cindy, we don't hear you. We're going to come back to you. Bill, you want to go ahead and introduce yourself? Oh, don't hear Bill either. Okay, now we do. No, we don't.
How's that?
That's better.
Yeah, all right. Bill Rowland, Lehigh Valley Hospital Schuylkill Counseling Center up here in Schuylkill County.
Fabulous. Welcome. Cindy's back. Let's unmute Cindy and see if we can hear from her. Nope, can't hear you yet.
Hi, ladies and gentlemen. Hi, guys.
So tell us where you're from, Cindy, for our new folks.
My name is Cindy Bello. I am the Hispanic Program Coordinator at Mars, Mid-Atlantic Rehabilitation. I'm also a prevention specialist for Lehigh Valley Counseling Solutions.
Welcome back. Karen? Karen just joined us on the phone. You're unmuted, but I don't hear you. Oh, you're muted. Now you're unmuted. Go ahead, try now. Okay, Karen, if you figure out how to let us hear you, feel free to barge in at any time.
Oh, okay.
Let's go around. Oh, there you are. Oh, tell us about you.
I'm sorry. Excuse me for joining late.
That's just fine. We're just doing introductions. If you can just tell us who you are and where you're from, we would love that.
Okay. Care Most, I work with the Newtown office. I'm a care manager for high-risk adults.
Fabulous. Welcome. All right, so we'll go around the room. We'll start with Heather.
Hi, my name is Heather. I'm a care manager from the COE at Neighborhood Health Center.
Hi, everyone. I'm Yamelisa Taveras. I'm the Project Director of Counseling Solutions at the Lehigh Valley and Drug and Alcohol Counseling.
Hi, I'm Jillian Beecham. I'm an emergency physician, toxicologist, and I do MAT at Lehigh Valley Health Network and Pyramid.
And you're a certified addiction specialist.
And certified addiction.
Yeah, okay.
Hi, I'm Chris Stewart. I'm a community nurse at Neighborhood Health Centers with Lehigh Valley.
Oh, and I'm Abby Letcher from the Neighborhood Health Centers of the Lehigh Valley as well. Okay, as always, challenging my coordination of all things. And then still does that. So still haven't figured out the problem of how to have just the slide show up, but bear with us, please. Today we're talking about pain management with people with opiate use disorders. There's a lot to talk about and think about here. We'll scratch the surface and hopefully have some good discussion. No disclosures. Okay, so today we're going to be trying to dig in a little bit to the complexities of treating acute and chronic pain in people who have opiate use disorders, understand some different approaches for treating opiate use disorders for people who are on medications for pain, and also look at how we might be able to understand the acute and chronic pain for people who are on antagonist medications. And we'll remind you what all those things are as we go through them, because sometimes it all blurs together. Okay. I think in primary care, and probably in the ER too, we think of pain and addiction as kind of the double whammy of stigma. That these are the patients that when we see them on our schedule, or you see them coming in, showing up on the board, or whatever it looks like these days in the ER, people sigh deeply and put on their armor. And I think what we want to talk about today is that putting on that armor is probably the least helpful thing that we on the medical side can do, because we actually do have the tools that we need to handle pain and addiction effectively, if we can put aside some of that stigma and the mistrust and treat our patients as people first, and listen to what they need and have to say. So some of the things that look, the way we embody or verbalize our stigma is talk about people as drug seeking, and the frequent flyers, but mostly that drug seeking, that's like a big red stamp on folks that says this person isn't really worthy of our care or attention, and nothing could be further from the truth. These are people who need us to listen to them more than ever. I'm interested that on this slide that was prepared by folks elsewhere that they talk about fear on both sides. And fear, I think, is often at the root of stigma, fear of somebody who's different, fear of somebody who's going to challenge your role or your sense of who you are. And on the clinician side, this is really profound. I think we don't talk about it enough in terms of fear, that, what is it that we are afraid of in patients who have pain and substance use disorder combined. And I think that when we unpack that, we find that we are afraid that we are going to do harm instead of good, or that we're going to be pushed into doing something we don't think is right. And these things are actually under our control. We can handle ourselves and face that fear and do just fine. So that's a big chore that both Jillian and I have been working on with our colleagues, and hopefully that will be something that we're working on even more in the nursing fields also, about how do we deal with our fear, because it causes us to sometimes abandon our therapeutic relationships with people and take on something else that's not so kind. On the patient side, we hear from our patients, and this list actually comes from a study that I think gets quoted in the end. They feel that they're having a lack of empathy. As a result, they're often not seeking care when they might or should, or looking for care in other places. We hear about lots of patients saying, well, it's easier just to go out and get something on the street than to try and navigate all those fill in your adjective doctors and nurses. And the fear at that point, we can kind of imagine and speculate, and some of us have experienced firsthand what is the fear of being a patient who needs to go and ask for something that we know is going to trigger the people that we depend on for help. Fear of rejection, fear of humiliation, fear of lots of things that have no place in our medical world. We shouldn't be doing this. Anybody want to put anything in there? This is my soapbox slide. We'll have lots of room to talk later if stuff comes up. All of you out there, feel free to jump in at any time. We do this pretty informally. So we talked about attitude, skill, and knowledge. And most of these, for those of you who are in drug and alcohol counseling, they sound really familiar. For people in peer support, sounds really familiar. Get comfortable in caring for people who have some complexity, who have substance use disorders. If we know that world, it doesn't look as mysterious and complex as it did when we didn't know about it. And maintain an attitude that's non-judgmental, trauma-informed, patient-centered. It's a lot of syllables, but mostly it means staying open to somebody and looking for their humanity and responding to that. Our skills are to be able to build rapport. Some of our, we don't have Hassan here today, but in our Promise Neighborhoods group, we talk about radical welcome. What does it mean to welcome everyone? What does it take within us to be able to find that rapport, even when somebody seems unfamiliar or difficult for you? The biggest skill is our motivational interviewing skills. How do we give somebody room to actually tell us where they're at, what motivates them, and what their goals are for themselves? And then we need to have some knowledge about substance use disorders and pain management. And I'm glad to be able to share this with so many of you in the care management world, so we can talk about where we're at in terms of some of the very basics of management and why it gets sticky. So for patients with substance use disorders who need treatment for pain, a lot of issues come up. And probably for a lot of you right now, stuff come up when we think about, well, someone has a substance use disorder and they have pain. First thing that we worry about, and our patients worry about it too, is relapse. So are they going to relapse? Because they may get exposed to triggers of being around opioid medications, or triggers of having pain or anxiety about pain. So our suggestions here are that we need to really explore with our patients what their needs are, and explain the rationale behind any of the suggestions that we might have for pain, and what are the risks and the benefits of each of those. Make a treatment plan with the patient. This isn't something we always do in medicine, and maybe not always something that we do in drug and alcohol counseling either. So what is a treatment plan with the patient? Encourage family support and system involvement. We know from the all of the work in addiction that family support and other support systems, that people do better. This is a time of high risk for folks, so bringing in all the supports that they find are useful is an important resource. Frequent follow-up and a multidisciplinary approach. So consulting when we need to, drawing in all the members of our team, and making sure that we have multiple sets of eyes on the situation together. One thing that's really important to know is that people who are opioid dependent have an altered pain experience. That means they're going to interpret pain differently from people who are not dependent on opioids. They have, in general, less pain tolerance. They have less pain tolerance. So when they're opioid dependent, when we try and add other medicines, you may need to add higher doses. We see that women who are on methadone need much higher doses after a cesarean delivery. So it's not just that they're tolerant to the medication and need a higher dose, but they also are going to experience more pain and need a higher dose to help with that. Do you want to add anything to that, Jillian, about just the sort of tolerance and pain sensitivity?
Yeah, just that I think it's a hard conversation to have. We know, I mean, there's a phenomenon, opioid-induced hyperalgesia, where individuals actually have more pain even from the opioid itself.
Right.
Methadone is a little bit less of a player in that. It doesn't do that quite as badly as some of the other medications, interestingly, but that people can be stuck in a cycle of they have a legitimate painful condition, they're started on an opioid, they become tolerant, and so experience pain. Maybe it's hard to describe how
almost more sensitive, like that central sensitization. Mm-hmm.
Yeah, and I think that's multifactorial, right? Mm-hmm. There's trauma and stress and whatever caused the pain, and there's worrying that the pain will be there, or that you'll run out of medication, and so all of that. What we're talking to our pain docs about this, we call this sort of black box of pain, which is there's pain, which happens at pain receptors, but then there's also stress and trauma throughout your life, and anxiety and psychosocial stressors, and all these other pieces that make up a huge part of pain.
Memories of pain.
Memories of pain, right? What's going to happen to me today? What if I can't sleep? What if I can't get back to work? What if I can't pick up my grandchild? And then on top of that, medications themselves can actually worsen that phenomenon. And so there can be so much complexity here, and to talk to somebody about that can be challenging, for sure.
Right. And I think when we're talking about making those decisions from a medical point of view, it can be very confusing because people may need more opioids to control that pain. They're having pain because of the opioids, and we may, with stigma, resent them for being dependent on the opioids in the first place. So it's hard to think clearly, and we see a lot of our colleagues struggle with that. And in a stigma world, we then blame our patients. So it takes a really individualized approach. Perceived pain as suffering, I think, is a really, it's an important lens to try and understand that folks who are at risk, who may have this black box that Jillian was talking about, where you have memories about pain, where you have altered sensation. These at-risk patients are folks who have experienced trauma, so past history of their own substance use disorder and the memories of things that have happened around that, emotionally traumatized, family experiences, early life experiences. We've talked before about the adverse childhood experiences. And oftentimes this is compounded with a lack of really effective and accessible coping skills for folks. So then we have a whole nother added thing. Actually, the patient we're going to discuss today, some issues there about when your learned response is to turn to the pill, it's hard to give room for other things to work. So this is part of that black box here. We talk about the uncontrolled pain cycle, that if you have pain, and we can start over there at about 11 o'clock, you get pain, you start to avoid the things that hurt, which means then you have decreased mobility because you aren't moving, because you're avoiding. Then your functional status starts to go down, which means that you don't believe that you can do as much. Your self-efficacy is lower. You don't think you can do as much, and you actually can't do as many of your roles. You limit your social participation, which then leads you to have more pain, and the cycle goes around and around and around. To turn it around the other way is possible, but difficult. So how do you turn it back the other way? I'm in pain. Let me reach out to my social supports. Let me believe that some of the decisions that I make can start to make a difference, that even if I don't feel it today, that it's going to have some efficacy in the future. How do you start actually functioning in some of those roles that you had started to limit, even in a small way? Start moving a little bit more, avoid some of those things a little bit less, so that you may have less pain. To do that takes an enormous amount of trust and belief in yourself and the people around you. And that is one of the things that is difficult for a lot of our patients, that they may not have a lot of relationships that they trust. This slide is here mostly to talk about, the extreme anxiety that goes along with pain for many people. Led in the period of time where we were prescribing more and more opioids in the medical system, that we were concurrently also prescribing more benzodiazepines. And we've talked before about the relationship between the opioids and the benzodiazepines is that there's much more sedation and likelihood of respiratory suppression. So you can see in this slide that as in the earlier part of the last decade, as the prescribing for opioids was going up and the prescribing for the benzos, that these deaths sort of parallel each other. So a really big effort has been made, and we saw that we turned the corner somewhat in 2016 with the leveling off and even decrease of some of the opioid prescribing. We're struggling now with the benzo prescribing, and how do we have options available for people for anxiety when we know that the treatment options don't have the same kind of effect as taking a benzodiazepine. So again, we need to have build the trust and the interdisciplinary team approach to help people understand that the options other than opioids for pain and other than benzos for anxiety can actually help them function better and do better, but crossing that chasm is difficult. Anybody want to add anything in there? It's an agonizing place for people, and I'm sure we've all seen folks who are in this position. So let's talk a little bit about what are some of the alternative therapies for chronic pain. Probably some of the most important, and we'll see this in a lot of our multidisciplinary pain centers, which are starting to show up in our community here in the Lehigh Valley. I think we're still behind many other communities. But being able to intervene at the psychological level, if we know that some of the problem is ramping up of our central perception of pain, then we need to help people learn to turn that back down. And some of the things that have been shown to be effective are cognitive therapy and other sorts of behavioral therapies, including relaxation and biofeedback, that help people notice their own cues and their responses to their cues and deactivate that automaticity that's between them. So we might be talking to someone who gets a lot of anxiety. Whenever they start to feel that knee pain or their low back pain, it triggers a memory of all the terrible things that happened to them when they were in the car accident and they got left by the side of the road and they were afraid they were going to die. Lots of things happen, but with some cognitive behavioral therapy, you may be able to notice that there's a disconnect that's possible there, and that you have other options other than going down that fear hole. And people do really well with this. So lots and lots of controlled trials have shown that CBT, the cognitive behavioral therapy, can be really effective. One of the pain modalities that we've talked about and yet haven't really gotten started yet at NHCLV is the sort of acceptance and commitment therapy for pain. There are group and individual curriculum for this to go through a process that helps people accept that some pain is part of their life, commit to doing what they can to have optimal function within the boundaries of what their body can do for them, and take small steps to move forward. And that has some great results with it as well. And all of that comes back to what you see in the bottom of the slide with the behavioral therapy. Like, how do you help people notice what they are doing and what they're able to do? Challenge themselves when they notice avoidant behavior that may not be functioning to protect them any longer, and set some goals and monitor their progress. when we talk about non-opioid alternatives to pain management, of course, for us that prescribe, we're full of all sorts of dilemmas because there is no perfect answer here. Our NSAIDs cause problems also with our kidneys and heart disease. So we don't want people on everyday NSAIDs, but intermittently these are really helpful and really effective, and probably we all underestimate how effective they can be for acute pain. The anticonvulsants like gabapentin, word on the street that there's some street value for gabapentin because it potentiates the opioids somewhat, but they're also quite helpful for neuropathic pain. You can see this is not a new slide, so what we don't have on there for some types of pain is the medical marijuana. Everybody's asking about that these days, and it can be very effective for some people with chronic pain, especially neuropathic types of pain, and maybe especially for people who are having a strong anxiety or PTSD response to their pain as well. And then topical agents. The only problem we have with our topical agents is that the insurance companies don't like to pay for these, but they're very helpful. Lidocaine patches, lidocaine cream, diclofenac cream can be helpful too. So these can be very helpful for pain if our patients can afford them. In our non-pharmacological category, I think these are wildly underused in our particular community, especially among people who have trouble affording to pay. Exercise, we know that physical therapy can be very helpful. If you have the right physical therapist who can work with someone with chronic pain, they can really help somebody start to work on the fear of movement. Small, incremental, supervised movement can be revolutionary for folks. We've used a lot of aqua therapy, having people get in a nice warm pool. And that can help get people over that first big hurdle of I'm afraid to move, because they're supported, it's warm and yummy in the pool, and there's someone there that they trust who says, let's just try it, see if we can get you to move that a little bit further. So the aqua therapy has been very helpful. Manual therapies like osteopathic manipulation or a good chiropractor can do a lot for people also. They can use muscle techniques or alignment techniques. And that we sometimes, the physical therapy and the osteopathic manipulation can be covered by insurance sometimes. So that can be more affordable for some of our patients. Acupuncture, great data out there for acupuncture for acute and chronic pain. Not paid for by most insurance companies. But what you can look for in your community are some of the community acupuncture programs. In Allentown, we have a group on 17th and Hamilton, more or less, that does community acupuncture where you may not get the in-depth individualized acupuncture treatments, but they do group acupuncture. So you get in your circle and nice lawn chair, relax, some music, and they'll do some good basic acupuncture that will help with relaxation as well as treating some chronic pain at about a quarter of the price. And then looking at things that some of our physiatry friends can help us with, orthotics, TENS unit, that those can be helpful for pain also. TENS unit is a little electrode things, and it does electrical stimulation. You can put it at an area of pain. And it's actually pretty similar to, in the end, it does something fairly similar to what the osteopathic manipulation does, that it tenses your muscles a little bit and gives them time then in what we call a refractory period to relax. So when you tense those muscles up, for a little while after that, you're relaxed more. And if you can use that to help yourself stretch gently, it can relieve some pain. Anything else you want to add about TENS unit? Yeah. They're a little bit bulky, but they're pretty portable, and they can be quite helpful for people when you have acute on chronic pain in particular. So if you have chronic pain and then you hurt yourself, a TENS unit can be pretty helpful to get you through that little moment. And then we have here some of the interventions that our pain specialists and some of these our primary care folks can do too. Nerve blocks we generally leave to the specialist. They can do ablations of a nerve that's causing a lot of pain. We can see this around the spine sometimes, or other, if they're having localized pain, a nerve block can be helpful temporarily. Steroid injections have are used a lot and have sort of mixed data about how helpful they are for people. And it's, again, a temporary stay, but it can really help people's pain for the short term. And that's something that we do in joints. Trigger point injections, that's more about muscle pain and muscle spasms that we can actually, the data out there for trigger points is that actually the dry needle itself does the most to disrupt pain, but it can help, probably all of you have felt that you have one of those little knots someplace, and when you push on it, like the pain just goes everywhere. Those are trigger points, and we can disrupt those either with manual therapies or with these trigger point injections, and they can be pretty helpful, again, to help somebody start doing their physical therapy or getting the exercise that they need to line themselves up better and start having improved function without a lot of medication. Okay, that was a lot of info in one little slide. Main point here is that there are a lot of things we can do for pain that don't involve taking a pill. Okay, so let's talk about people who are on agonist treatment. And agonist treatment, we might remember, is methadone or buprenorphine. It's the ones that are sitting on those mu receptors. So if they're on agonist treatment for opiate use disorder, what do we do if they hurt themselves? Great question. So here's our basic suggestions, and I can see what, if you guys have other dilemmas or thoughts about this, again, chime right in. Mostly, we want to keep them on a stable dose of their methadone or their buprenorphine. Both methadone and buprenorphine are really good for pain, but the pain effect lasts less long than the effect that suppresses your cravings or your withdrawal. So, and I think we talked about this in a previous session too, that you can do a once-a-day treatment with buprenorphine or with methadone, and for 24 hours at fairly predictable doses, you don't get cravings, you don't get withdrawal symptoms, and it sort of blocks, if you're taking any other opioids on top of that, will block some of those effects. So we say that they're good for pain, but that pain, the analgesia or anti-pain properties don't act for as long, usually for about 3 to 6 hours tops, and we've got a slide that will show that. So in general, and I think this comes down later, what we do is try and split those doses. If they're coming to NHCLV or to Pyramid for buprenorphine, we'll suggest instead of taking the medication once a day, even at the same dose, if you split it up into maybe 4 doses, some people do fine with 2, but people that are really having a lot of pain, we split it into 4. We don't need to increase their dose, and they do really well. That's trickier when we get to methadone. We'll talk about that in a minute. If you do need to use opioids on top of what they're using, they're probably going to need to use a higher dose. And that's where it starts to make all of us who are prescribing a little twitchy, right? And probably those of you who are hearing about doses that people might be getting in the emergency room or something else, raise your eyebrows with questions, but they may need a higher dose. If we don't treat pain inadequately, that's probably a higher trigger for relapse than having accessibility of Percocet. So we need to consider really carefully and seriously, what does it mean to undertreat somebody's pain? Just as much as what does it mean to, how do we put together a good interdisciplinary plan for their pain? And don't use the mixed meds, but we don't use those very often in this community. Anything you want to add there? Okay. So methadone is tricky because, and I think we have a slide out here that will show this more specifically. Methadone's tricky because to treat the opiate use disorder, you must go to a methadone program, and they can only give you a once-a-day dose. So they can't split the dose because you have to take it right in front of them. You have to take the whole dose. So that's not an option for a person who's on methadone treatment for their opiate use disorder. So what our internal medicine and pain medicine folks suggest is that you need to add an opioid on top of that for acute pain, or if they've been to surgery, and that they're going to need a pretty high dose. So this is a situation where you want some support from a specialist to help monitor that and make sure that your patient and the family and their entire support system are aware of what's going on. It's tricky. How do you know how effective this is for the pain? It's important to have good ways of talking to your patients about this and make sure that you're able to receive that information. We want to be able to determine what's pain that actually is getting treated by the opioid and what's pain that's actually your withdrawal. Sorting those out can be kind of tricky. Been there myself, not being able to tell the difference until we dug much deeper into the questions. But if the pain is coming back in 6 to 8 hours, that's probably opioid responsive pain, meaning that the opioid that they are taking was helping to control that pain, and as it wears off, their pain is coming back. If it's more like 24 hours after they take the methadone that the pain is coming back, that's when the protection from withdrawal from the methadone is wearing off 24 hours later. So that's probably more likely to be your withdrawal pain. So paying attention to what is the timing for when they're experiencing the pain can help you figure out, is it withdrawal or is it that they have this underlying pain that's breaking through the medication that they're taking. Does that make sense? As I mentioned, if we're recommending that the best pain management with methadone would be at least twice and maybe 3 or 4 times a day, the methadone clinics can't do this. If we're adding an extra opioid, that makes drug testing from urine more complicated to try and figure out what's actually going on for somebody. Yamalisa and I were talking on the way in that if we were going to be treating with methadone, you'd need 2 prescribers. You need your methadone program and you need a partnering physician who can prescribe methadone for pain, and I've never seen that happen. So most likely this isn't going to be an option that's available to our patients. We have, what we do need to do for a patient who is on methadone and has acute pain or is going to go for surgery is we have to partner and talk to each other. So getting all those right consents signed and making the effort to talk to the methadone program so that they're aware of what's going on and that everybody can get together around a plan, and that we have an idea about how to monitor how people are doing with that plan. And monitoring both means, this is sort of coming back full circle, how do we know that the pain is adequately treated and so that we're preventing relapse that way? And how do we know that that the person is using the medication the way it's prescribed? So those are all conversations and no magic answers. Buprenorphine for pain, still complicated, but less, I'll say, black and white than the methadone. We have different formulations of buprenorphine that are approved for treating opiate use disorders versus those that are approved for treating pain. But it's not quite so difficult. One, because it is office-based treatment, so I can prescribe more than just buprenorphine if I feel that's clinically appropriate, so we don't necessarily have to involve multiple prescribers. And I can use the buprenorphine that I'm giving somebody for an opiate use disorder off-label for pain. What becomes difficult is talking to insurance companies or other entities about what we're doing and why. Because if it's off-label, insurance companies don't need to pay for it. The other forms, transdermal forms, are not approved to treat opiate use disorder. We personally don't use them very often. And more often what we end up doing from our office-based treatment is having people split doses. Thoughts? This slide is showing that when we need to, it may be safe to increase the dose of buprenorphine for a period of time. Some of our folks that have been going for dental procedures, this is sort of a plan that we might have of we're going to do split doses and increase the dose a little to give you a little bit of extra coverage, and then wean you back down once that acute period is over. And the question that this study is trying to answer is, if we go up on the dose, are we putting people at risk? Is there more of a problem with respiratory depression and overdose? We would expect not, because we've been talking about how there's a ceiling effect, and that buprenorphine, even at some of the higher doses, does not cause more respiratory depression, or that you stop breathing, and that's the overdose. So these two lines here on the left with the black circles and the white circles shows that even at a higher dose, the buprenorphine didn't cause more respiratory depression. We still saw that ceiling effect, so relatively safe. But the spread of those white circles and the black circles in the second half of the slide shows that for at least, and you can see 180 minutes, it starts going down at about 2.5 hours. The higher dose in the white circles got a lot of pain relief for at least 2 to 3 hours, and more than the lower dose for up to 8 hours. So that's pretty cool. So what do we do for someone with acute pain who's on buprenorphine? Try and stabilize them with non-pharmaceutical methods like the acupuncture, the physical therapy, behavioral therapies, split the buprenorphine dose, maybe go up on the dose for a little while, possibly consider adding a full agonist to the buprenorphine, but we'll talk about that a little bit more. And some of the older guidelines talk about actually stopping the buprenorphine and then starting a full agonist like morphine or oxycodone. That's doable, but tricky, so we don't do it. For major surgical procedures, we have them often actually even go through the whole thing with their buprenorphine. What I wanted to draw your attention to is on the bottom here, is that we can continue the buprenorphine all the way through and just add the opioids on top for additional pain control. When we do that in a supervised setting. This is not what people do at home, because they need to be monitored in an ICU often for that kind of dose of opioids on top of buprenorphine. And particularly, we'll get to that for naltrexone. So how about someone that hasn't had an opiate use disorder diagnosis already and has a lot of pain? When is it a good time to think about talking about buprenorphine with them? And this, I'll say, has been a really useful tool for me in primary care, where I see a lot of people with pain and a lot of people with opioid use disorder. Sometimes that line in between is kind of hard to navigate. So for some of our folks, especially now that we're trying to wean people off long-term opioids, probably isn't as effective for pain as we thought it was even when these slides were prepared, that buprenorphine can be a really helpful option for people who can't wean down to 0 on their oxycodone or their hydromorphone. So as we're trying to wean people and we find that they're having increased pain and their functional capacity is going down, those might be patients that are good to switch to buprenorphine for their pain in split doses. This study looked at a group of people and showed that when they were, I think it's 95 patients that were in this group, that 8% of them were diagnosed with an emerging opioid use disorder. Probably the number was higher than that, but that's what happened in this study. They put people on the buprenorphine, and in general, they had some good retention and treatment with very few people saying that their pain was inadequately controlled. So this is a nice sort of early study back in 2005 and repeated a couple of times that showed that this is pretty good treatment for pain, and I would say our own experience has borne that out for us. So when we're doing this for pain, my workaround is that usually those are people that I then do diagnose with an opiate use disorder because we're having trouble getting them off and they're having trouble controlling their use. But even if people do not accept a diagnosis of opiate use disorder, we can do this off-label. These dosing regimens are for our primary care partners, so we don't need to go into any detail for that, but splitting it 2 to 4 times a day is usually what we do. And I think this is an interesting study. You know, we worry about, for many of our practices that are just getting started with the medication-assisted treatment, they're like, we just want the simple patients, not the people with co-occurring mental health disorders, not the people with chronic pain. We thought that way for a minute at NHCLV also, until we realized that all of our patients have chronic pain and all of our patients have co-occurring mental health disorders. So we needed to just build our skill set a little faster. And this study is one that can help to suggest that people who have chronic pain actually do pretty well on MAT. That it can help control their pain, it can help control the anxiety, and they do pretty well with retention and treatment and relapse prevention. Okay, so what about someone that's on extended release naltrexone? The buprenorphine is relatively easy. If you have an anesthesiologist who really feels they need to be off it, that can be monitored, and we can, in a day or 2 or 3 days, all that effect is gone. But the extended release naltrexone, that's your Vivitrol, that's in there for a month. What do we do if somebody has a problem? What if they get in a car accident and they have an acute fracture of some big bone and it's really painful and they need more, they need surgery? First thing, if it's not one of those situations that I just described, we've got a lot of other things to use for pain other than opiates. So focus on those, the non-opioid medications and the non-pharmacological therapies. We've talked about those already. Most of the time we do okay with that. But if they've got severe acute pain, then we know that the opioids are going to be blocked, maybe for weeks, depending on the timing. This can be pretty scary for clinicians and for patients. So first, you're going to optimize everything you've got. And then if they do need to be on an opioid infusion to try and power past the naltrexone, they need to be in the ICU. And they need to be monitored very carefully because as the naltrexone starts to wear off, the opioids are going to have more and more effect. And the risk of overdose is substantial. So we need constant monitoring. Have you seen many of these patients?
Yeah, I think you make a good point that kind of depends on where they are in their lungs. A lot of control, you can feel it wearing off. They feel their cravings increasing. So yeah, we developed a whole order set and training for all our anesthesiologists about what to do, and we're training our medics too, to recognize that someone, they have a dog trap tag, a bracelet, or a wallet card, and be on control, and that. In that case, you wouldn't really know where they are in their cycle, and that non-opioid treatments need to be used. And same thing in the ED and the trauma bay. And then in the ORs, we can plan a little bit more carefully to schedule, say, knee replacement at the end of the months. Maybe they transitioned to oral naltrexone for a while, so we just continue a few days before. But that, yeah, the risk is that the opioid you're using isn't going to do anything,
And then
increase the dose, and then
it's a whopper.
people overdose.
Mm-hmm.
So I agree with you completely that I would want them in the pre and post op setting and full monitoring and keep a close eye.
Mm-hmm. Right. And sometimes we can't plan ahead. Sometimes we can. So if we're talking about elective surgery, then we want to get the timing right. And we've had a few patients that have navigated this pretty well. And I'll say our repeat message of the day is that for our patients to manage any of these transitions well, this is really scary stuff for them. And that we know that clinicians tend to underestimate that the pain that our opioid dependent patients are experiencing, and that by not hearing people and responding to what they're telling us about pain, we are increasing their risk of relapse, which will be very dangerous for them. So we need to be able to hear them, but we need to also remember the whole range of treatments that may be available for them for their pain. I think that was the summary, actually. Let's see, what did I miss? Right, so the basic points here for pain and opiate use disorder is that it's complicated, that people should stay on their maintenance medication the best that we can, and that we need multidisciplinary full range of care for folks. What questions do you guys have out there? Or comments or thoughts? All you have to do is unmute, share with us what are some of your questions or experiences with patients with pain. We can start with, have you ever had a patient with pain that you felt was frustrating or didn't go the way you wanted it to? Cindy, can you unmute Cindy?
I just did.
You did it. Awesome. All right.
Okay. Well, this is Cindy Bello. We do see clients. This is a very good topic because I believe as clinicians, one of the concerns we always have as a team, I can talk for the people I supervise as well, it's to know what it's behavioral and what's physical, and then keep that empathy in between and know that we're doing the best we can, respecting the medical side, but also keeping in mind that there are so many personality traits with patients with addiction, in where, for example, they perceive things worse as they really are. So this is a very, very complex topic. And I'm grateful that we can hear from the medical team how things go, because usually we just get what the client is telling us. So yes, this is very, very, very common, especially at Mars. We're one of the few providers that accept patients on their mat, and we're dealing with clients who are receiving medical maintenance for their either chronic pain or their addiction, but also they have this behavioral component. So yes, this is very, very common.
Yeah, and I'm so grateful that you talk about the behavioral component, because I think that in some ways that's the part that the primary care and the emergency room physicians or prescribers tend to shy away from, and that we may not feel that we have the tools to handle in the course of our own office or ED visits about how are you coping with pain, how are you coping with anxiety, who do you go to for help or more formal sort of CBT type therapies or other sorts of things to retrain your own responses to the pain. We may not feel we have much to offer there, so then we're feeling sort of stuck and crunched between, do we give them opiates or not, when there's just a whole range more of options that we can be talking about. I know for us at NHCLV, we've had to reach out. We actually are excited that we have a physiatrist who's a physical rehab and pain doctor who comes to our office and helps us with the MAT, so we get to pick his brain about some of the chronic pain course folks. Good partner at Good Shepherd who works with us with our chronic pain patients, and all the physical therapists that we've discovered who are awesome at chronic pain. That makes it, we're able to relax a little more when we know that we've got partners who can do the behavioral health and the sort of physical modalities as well. And then we got more empathy because we've got more tools.
Yes,
Yeah.
absolutely.
Okay.
There's one more layer that I was thinking when I was listening to everything, and that specifically geographically, we do have a lot of minorities around in the Hispanic culture. We're dealing with the macho image, and culturally, we are not raised addressing anything more than the symptoms. And that's a lot of education that needs to be happening with our clients, because you spoke about mindfulness. That's speaking a different language. The client, yes, you can do this X, Y, and Z, but they won't even have a clue, nor they might believe this is something that it's accurate. So there's that stigma that comes with pain, that to explore further than the symptoms, it's easier to either go outside, get high, or go get a medication, and that should do it. So there's a lot of education to happen in session, whether it's with the medical or in therapy, to help them get that educational piece that they will have to learn because they don't know anything better.
Yeah, and get a chance to practice, which without being able to pay for things can be difficult. We do a lot of breathing exercises at NHCLV. It's good for me too. All right, what do we have going on?
We have a Julie.
Oh, Julie couldn't hear what. Okay.
And then Rosemary had a question.
Yeah, so Jillian Beecham said all sorts of wonderful things, and I didn't notice that we couldn't hear you very well out there. So you get to shout into here when you talk in the future, but do you have a key point of the things you said that you want to repeat? I know it's hard.
We're talking about the ICU and the anesthesia.
Oh, yeah. So the issue that we were discussing was just with patients on Vivitrol, so a full blocker of that receptor where opioids act, that we have to be very, very careful. We educate our patients all the time. If you try to use an opioid to overcome that blockade, and you start with a small dose and kind of escalate those doses, that nothing will happen until everything happens, and then you have a full overdose. And that's how we lose patients on Vivitrol, which is pretty scary. And so we've developed some protocols with our anesthesiologists so that they know how to handle, say, a patient comes in who's been the victim of a trauma and needs an emergent operation, how to manage those individuals. And we recommend a lot of monitoring, very, very close monitoring, to make sure that we always say to start low, acknowledge that if an opioid has to be used, you may have to use higher doses than usual, but to escalate slowly and with very, very close monitoring as we go along.
Right. And education, involving those patient support systems, all of that matters a ton. The other question from Rosemary is, who is engaged in piloting multidisciplinary pain management in the Lehigh Valley? Great question. I think there's lots of small pilots happening, but I'm not sure that there is a good overall strategy through LVHN, and I haven't heard of anything coming through St. Luke's either. Kevin McNeil, who sometimes has been on some of our calls, is primary care clinician out in Hamburg, and in his office, They have piloted some group medical visits that include primary care physician, some osteopathic manipulation, and a social worker who is doing a cognitive behavioral therapy curriculum with those patients over the course of 12 visits. I haven't heard what their outcomes look like, but the people who were participating, at least in a kind of verbal way, were saying that this was really helping them with their pain. We've seen a bunch of that elsewhere that has had really great outcomes, but that's one pilot that I know of that's been happening. And then I know, our looking at some of the Good Shepherd and the physical medicine and rehab folks there, they have pain psychologists who are on site and can meet with their patients. So some of our more difficult folks we like to send over from NHCLD, we send to Good Shepherd, but we have good physiatrists at each of the hospital networks that can have some interdisciplinary teams. I've heard, Rosemary, that the group out on Tillman Street has an interdisciplinary team, and they have a pain psychologist on site there too. And probably in an ideal world, we should have pain psychologists available to any practice that's treating people with pain.
I agree. Yeah, I think at Tillman, it's an interesting model. They're calling it's the Advanced Spine Center, and now it's become, I think, the musculoskeletal center of some kind. Mm-hmm. And so the idea is that embedded in that same facility, at least through a referral process, is physiatry and chiropractic medicine and physical therapy, occupational therapy, neurosurgeons, pain specialists, our PM&R folks, physical medicine and rehabilitation. And an idea has come up about, there are a lot of patients there who have kind of crossed into that spectrum of having developed an opioid use disorder, mm-hmm. Through chronic opioid use, and that I was approached and we sat down with some of our pain docs to say, what if we also had MAT there, mm-hmm. and could transition some people who were appropriate, who had both chronic pain and opioid use disorder, to MAT, and then what would that look like in terms of getting the counseling piece done? Would it be a chronic pain group, a special group, mm-hmm. for people in that situation that really would address that chronic pain? And that's something that we're kind of brainstorming. And that would truly be, I think, a multidisciplinary approach if we could address even that end of the spectrum. But even there, where I think that's one of our better models, and there are chronic pain groups already there. Steve Denton, I think, mm-hmm. leads those. I don't think we're doing a lot of CBT, exercise therapy necessarily beyond the PT. I think there are missing pieces, and the issue is that insurance doesn't pay for it.
Right. So these are hard for a practice to support because they end up costing our medical practices money, and that's
think we have to do that because ours is different.
Well, try, what is it, star 6-1?
Oh, you hear us now?
Hearing now.
Oh, good. All right.
Okay.
So I believe what we might have been saying before we had our technical glitch number 97 was that the VA has been doing some really good research on folks that have the vicious triangle of opiate use disorder, chronic pain, and PTSD. Can imagine that the VA has a large pool of people, but they've been doing some amazing stuff. Some of the data about the assertive, acceptance and commitment therapy comes out of there. And there are lots of tools that could be available to our practices, both primary care practices, drug and alcohol and behavioral health practices, around trauma and safety, including the Seeking Safety curriculum, that there's lots and lots of data behind that, and that can be something that really helps people with their perceived pain as well, because pain is all about a signal from your body to your brain that you're not safe, and people with PTSD have a much heightened sense of not safety. So if we can help train people to create environments that feel more safe for them, then oftentimes we do a little bit better with treating their whole triad. And the last one that I want to mention that's not local at all, Rosemary, but the last is in the addiction medicine world, a guy named Corey Waller, who's a very entertaining man in and of himself and a great educator, but his early experiences were in setting up a program adjacent to the emergency department for folks who were coming in looking for treatment for pain repeatedly. He had a sort of program on the side, and he said that he found that the most important first step was to put them on buprenorphine and calm their whole system down. And then they could start talking about pain, and then they could start talking about some of the behavioral therapy goals as well. And he ran that clinic for, I think, at least 5 years, and had some great results with that out in Michigan. So those are things we could be doing locally, and we're starting to think about it.
What's his name, Abby?
Corey Waller.
W-A-L.
2 L's, yeah. He runs the pain and addiction threads for us.
Mention the name of the one on Tillman Street again. Someone stated previously what was
Tillman, yeah. So they were called the Advanced Spine Center, and now they're called what? You said musculoskeletal.
Changing it, yes. It's not just back pain, but it's musculoskeletal center or something like that.
Okay.
Yeah.
Intensive.
Yeah, and what we find that we need to do with our patients who have a lot of pain, usually pain is what we call multifactorial, that it's not something that you can say, yeah, it's the bones, no, it's just the nerves, oh no, this one it's only the muscles. Usually it's a combination of all of these things. And many of our pain specialists, all of us, we focus on one thing at a time. And that's not good enough for folks that we're talking about who have trauma, who have anxiety, who have pain, and who have a substance use disorder. That their bones, their nerves, their central nervous system, their peripheral nervous system, all of it's entrained into their experience trying to protect themselves from danger. And to try and untangle that spaghetti is really complicated. Yeah. Okay. Any other thoughts about pain, addiction, trauma? All right, so as we transition over to the case, we've got some new people to introduce themselves. We'll start in the room here. We've got 2 fabulous students. So if you can just say your name and what program you're part of right now and where you study and what.
Okay.
Yeah.
My name is Nicole. I'm at DeSales junior nursing student. And my name's Nicole. I'm a junior year nursing student at DeSales University.
And what program are you part of this summer?
Alliance Fall Summer Camp. And with you guys, Bridging the Gap, yeah.
It's got to be our commercial. Yep. Okay.
My name is Trexney. I'm also with Bridging the Gap. I'm also with her at DeSales University, nursing student, 3rd year. And I'm going to be working at Casa Guadalupe Summer Camp.
Next generation. Woo, bulldog. All right, who else we got at here?
Well, we have a phone, I don't know who this is, I need their email address.
Okay.
484-526-1576.
All right, who's our 484? If you can unmute yourself, 484-526-1576.
What is it, *6-1? No, doing it over the phone.
Yeah,
So let me know what it is.
*6. *6 to mute or unmute. And we'll try and unmute you. Okay, you're unmuted. Can you introduce yourself?
Hey, this is actually Rosemary, since I don't have the audio on my computer.
Okay, so you're doubled up. So Rosemary, tell everybody where you're from.
So we're from St. Luke's Community Health, and I actually have Matt with me. I'll let him introduce himself. Go ahead, Matt.
Hi, my name is Matt Astek. I'm a second-year medical student at Temple St. Luke.
Yay, another next generation. Joshua.
Hello, can you guys hear me?
Yes.
Okay, sorry about that. So yeah, my name is Josh Rosenthal. I work in the quality department here, and I have done a lot of work, in different areas of the opioids with both Jillian and Kevin through a multitude of different factors over the past 2.5 years.
Awesome. When you say here and you mention Jillian and Kevin McNeil, does that mean here is LVHN?
Yes, correct.
Got it. Okay. Quality at LVHN. Glad to have you.
Thank you.
Is there anything
Glad
else?
to be here.
Peter? I think that's everybody.
I think so, yeah.
Oh, and I didn't do my job. Sorry, people. So we will switch to a case.
Try clicking on slideshow at the top and move that way.
This one?
In the bar. See if it's like, yeah. And then from beginning. See if that changes anything. No. Okay. I tried.
Have it. You have it? Yeah. Okay, you tell me when to go forward. Okay, so we're starting. Okay, so the case that I'm presenting today, he is a 52-year-old Hispanic male. We're looking for help with non-medication treatment options. He is not aware of the presentation and did not help develop the questions. Strengths for this patient, he's very family-oriented, loves his wife, loves his children. He is independent. The question we have, what type of behavioral health techniques can we use to help him become more open and honest about his recovery? Yeah, and I added in there, part of my question is how to take on some self-management for his medical stuff too. Okay. Did you have anything else? Maybe. Okay, so you can just jump in. Okay, history and support. This patient did begin treating with neighborhood health centers back in January 2018. He's engaged with the COE Care Management Program, MAT Suboxone, and also our social workers for counseling. He's made multiple recovery attempts. He has attended and completed IOP through MARS and continues to receive individual counseling there once a week. The patient lives with his wife, who he does report is supportive, and also his children. His education, he does report completing 10th grade. He does have a history of legal involvement and incarceration due to drug charges back in the 80s and 90s. There was a traumatizing event in prison that happened in about June or July, but he doesn't really talk about specifics very much. He's also unemployed and currently receiving disability. The current UDS does confirm fentanyl, substance use history, alcohol first use was age 11. He reported that he would drink socially on weekends, last use age 34. Marijuana first use age 11. Said occasional smoking, last use age 18. He admits to hallucinogens, first use 17,
used about 45 times, and then stopped using around age 18. Heroin's first use was age 16. He would use up to 1 to 2 bundles daily, and then last reported use was May 31st of this year. Methadone, he first used at age 40. He was going to a methadone clinic. He reported that he didn't like it and continued to use while at the clinic. Crack cocaine, first use age 15, admits to that past use around 1991 he stopped. Denies any kind of depressants, amphetamines, or club drugs. He does currently smoke about a half a pack of cigarettes daily. Medical behavioral diagnoses, he has been diagnosed with opiate use disorder, PTSD, major depressive disorder, diabetes. He has a history of DVT, hypertension, and asthma. The medications, do you want to pronounce all those?
There they all are. If you have questions about them, we can come back to them. He's on plenty. I can just add in there that for his history of DVT, he has a blood clotting disorder, so he's on anticoagulants for life.
So he has been engaged as far as treatment with Neighborhood Health Center since January 2018. He did attempt a methadone maintenance program through New Directions in 2006 up until he went to prison, but he didn't report that it was successful for him. He reports history of inpatient stays at 3 different facilities in New York around 2001. He has been attending Mars for outpatient counseling, and he's engaged with the social worker at NHCLV for mental health. He does report that he's tired of using. He wants to be healthy for his family, but he does not disclose recent use.
Yeah, I added a little bit here.
Identify goals. Patient states he is doing well and no need for goals. He suggests follow-up locally for lab draws. Contingency management. Considering making a mandatory transition to Sublocade from the oral, or refer back for methadone. Encouraging engagement at the Coumadin Clinic for anticoagulant management, and continue to facilitate a welcoming environment with open communication.
All right, peer summary. So we have a 52-year-old Hispanic male, currently has supports from family, including wife and children. He has a compound history of medical and substance use, as well as mental health, currently on Suboxone, provided a positive urine screen for fentanyl recently. However, it sounds like he's denying use and or relapse. And he appears to be externally motivated more by the family, even though he states to be tired of using. But
that sounds just about right. Yeah, I think what's really tricky about this guy is that he's super friendly and really good at engaging. And he had a relapse around last year, around this time of year, which is a tough time of year for him, and it took him quite a long time to be open about it. And now we're worried that we're in a similar pattern. So how do we do better this year? How's that?
I like it.
So the way this works for those of you who are new out there in the Zoomiverse is first we'll ask clarifying questions for the presenter. So things that you would like to know about this patient. What else do you need to know to make decisions? What are you curious about? And then we'll open it to you out there first. Then we'll go around the room with some questions from our specialists here. And then once we've exhausted all of our questions, then we'll go to some treatment suggestions. So try and keep separate that first we're asking clarifying questions, and then we're thinking about what might help this guy out. So what kind of clarifying questions do you have out there? Anything is open for questions. What do you want to know about this guy?
Is he currently in any mental health counseling? I don't recall.
He sees a social worker through neighborhood health center. He's not engaged in any kind of outpatient mental health elsewhere. He has not been so good at actually coming to those appointments recently, I don't think.
And I might suggest that on our end, that folks that are coming to see the social worker with us, we try and coordinate that with their appointment.
Mm-hmm.
And sometimes I would say that for someone with high needs, it's probably not a high frequency counseling.
Mm-hmm. Yeah.
It's more of a check-in.
Okay.
So no. Other questions? Let's get to know this guy.
I have a question.
Mm-hmm.
Is there a language barrier?
No, I wouldn't say so.
He's fluent, bilingual. Great question.
Okay.
I think he prefers English. Okay. But I would think that. Over to you. Okay. That was Spanish. Other questions? What do you want to know about this guy? I'll point out that he has told the social worker all about what happened.
And I think something to point out too, he does not really allow for family involvement. I've tried multiple times to go to the home to meet the wife, and there's always a reason for that not to happen. So that might be something.
His daughters are old enough too, right?
They're like adult.
He also has older daughters, and he doesn't include them in his recovery either.
Are we in the room? Or are we still out there?
Let's get a couple more questions from our out there.
He's been through a lot of, I'm sorry.
Go ahead.
He's been through a lot of treatment in his past, and I know that some of that has been kind of several inpatient rehabs, outpatients, et cetera. How well has he done in terms of any type sober time or like what's worked for him in the past, if anything?
I believe the longest he has had in recovery is 3.5 years.
Okay.
I want to say. And I believe he did it through, like, with the treatment, going to meetings, and having that support.
What is that?
So was it methadone or was it?
No, I don't think that was when he was on the methadone. I can look. Can I look?
But it's been a long time. How old was he when he started? You said he was 17?
16 opiate use.
And he's 52. And it's the longest period he's had is a few years. That's a lot of using. Yeah.
Maria has a question. There was a mention of potentially utilizing Sublocade. Are there currently any providers in the Lehigh Valley offering Sublocade? If so, which providers?
Yes. NHDLV offers Sublocade. How many patients currently?
Close to 50.
So about 15 patients on Sublocade. And Sublocade is a monthly injection of buprenorphine. Starts for the first 2 months with a loading dose and then a maintenance dose that's lower after that. I'll say Heather's looking that up. Our first patient is an interesting guy, and he was pretty sure everything was going to go terribly and that he was going through withdrawal, and that turned out to be mainly his anxiety and other behavioral issues. He's maybe 6 months in now, doing great on the injection. So we found that for people who are really struggling with the ambivalence day to day of whether to take the MAT or not, but who really are pretty sure that they do want to follow this journey into recovery, that it's a powerful option. It will end up having some of the same concerns that we have with naltrexone in terms of, like, what about surgery, what about pain management for serious acute issues, but we're getting better at that, so we're not as afraid of that as we were before. I've even thought that it could be particularly useful for some of our patients. One of the high relapse potential times has been when people know that they're facing incarceration, that this might be useful because it lets you down nice and slow.
It doesn't look like it was from the methadone. I know there was a point in time in the early 90s that he did a 1 year, like, inpatient kind of facility, like a long term. I think that might have been it.
Okay, and lots of support.
Yeah.
Okay. Great question, Bill. Thank you. That's what we didn't know.
I'd like to add on with the Sublocade, with really any monthly injectable, just to, anytime that's being used, just to always check in with patients on their mental health and make sure they're consistently engaging with that, because they feel that sometimes patients who start with monthly treatments like that, they feel like they're okay, and sometimes that mental health aspect can be not paid attention to, and that can lead to issues as well. So.
Right. I think one of the things we've really liked about MAT for this group of patients that have such complicated issues with trusting relationships is that we see them a lot. So we can check in, we can get a lot done in the course of a visit. But then all of a sudden, if we're seeing them once a month, that's a lot less intensive involvement with them. And I think when we talk about the sort of continuum of care that's available for people, that there are a lot of drop-off points that are sad and dangerous, of when you're done with IOP or OP or intensive or just your outpatient, and all of a sudden those connections aren't really there for you anymore. Or for us, when you graduate to monthly or even every other month, if you don't have the support you need, and we're backing away from people at that time, what are we missing in our community that could actually provide the support in the best possible environment?
It's opening Friday.
Oh, what's opening Friday?
Oasis Community Center for families and those affected by substance use. It's opening here in Bethlehem.
Is there an event?
There is. There's a ribbon cutting on Friday, and then the official opening to the community is Monday, July 1st.
Thank you. Note that down. Yes. Let me do that. Any other questions out there? You can chat them in. We can see you.
Clean Slate will also be offering Sublocade in the future. Starting in the future.
Right. So Clean Slate is the newer MAT, sort of low barrier MAT practice. We're really hoping that they're a useful partner in our system here. All right, let's go for questions around here. Oh, was that somebody?
That's me again. This is Cindy. Question. He's disabled due to why he's disabled? Why he was determined disabled? Is it physical or mental?
That's a really good question.
That's my question number 3.
Go ahead.
You write them down.
I would say currently that he does not have a huge physical disability. It's more the mental health, but he does have significant chronic pain issues.
Okay, because that's a very important question, because if he has a disability and it's a mental disability, probably he'll benefit from a different setting and a lot more support in that area, because it sounds like he's just he's only attending substance abuse treatment, and it sounds like he might benefit from support group when it comes to his mental health. And my other question was, does the treatment provider is aware that he provided a positive for fentanyl?
Yeah. Yeah. But is his drug and alcohol treatment aware?
That I don't know.
That's a very important point as well, because we have a lot more leverage and to address this in just little pointers and questions that I have just listening to the case. Yes.
Great questions. Thank you, Cindy.
You're welcome.
All right, Annalisa.
The trauma that occurred in jail, how long ago was that?
He was incarcerated early 2000s.
Yeah, I was going to say about 10 years ago, but it sounds like it's longer.
Okay, so over 10
He
years.
has some childhood trauma as well.
Okay, and this, he's, like you said, he's disclosed to the social worker.
Mm-hmm.
Okay. The other, that physical disability was one, family awareness, you already answered. Are there, well, when he entered treatment, where was he transitioning from? When he when he entered the COE?
I don't think he was transitioning from anywhere. He was in active use at that point.
Okay.
And we had sent him to Mars for like the level of care and to get engaged there.
Okay.
Did he self-refer or did he refer him? He said, okay, I can look.
And then if you can take a peek at when you guys wrote the crisis plan with him, what he identified as warning signs and and ways that he copes. Because then my next question is, what are the things that he enjoys, things that we can engage him with, and he can possibly express himself?
His warning signs that he acknowledged were depression, lack of motivation, and lack of self-worth. As far as coping skills, it's kind of all external, like being busy at home, going to the movies, hanging out with the grandkids.
Okay. And then the last question is, what is he looking for in treatment?
That's a good question. I think he wants to be in recovery. He genuinely wants to do this. I do think that his mental health is a big struggle for him, and that he's afraid. I don't know if it's fear. Opening up about it is not easy for him. After his relapse last year, he did tell me about the trauma. I think 2 meetings we talked about it, and then he wouldn't talk about it again.
He shut it back down.
He shut it back down. So I think that's a root of a lot of the issues that continue to come up.
Okay. I'll hold suggestions.
Jillian, what kind of questions do you have about this guy?
I guess I'm hearing he has all these issues, and then the only thing that I hear you say about his presentation is he's an incredibly friendly guy. So I'm trying to think through. So there's clearly a disconnect there. It's part of the problem, I think, how to get through to him. If you ask him what concerns him about his substance use, is he able to describe that at all? It sounds like he can describe his support and sort of a general sense of motivation. But does he, like, is he worried about any aspects, or is that a missing?
The last time I talked to him, his thing was he's afraid to die, so he doesn't want to continue using. What was the rest of the question?
Just like if you were to do motivational interviewing, what concerns him?
I think his big thing is not being there for his family. Okay. But he engulfs himself so much in this family that he doesn't really take care of himself. Right. Like, he will miss appointments, he'll put off doing things he needs to do in order to take care of everybody else.
And his physical health, I'll point out, is not great. He's very obese. He's got this coagulopathy, this blood clotting disorder. We're trying to monitor that, but he doesn't answer phone calls and doesn't come in to repeat draws, so he has prolonged periods of time where he's not on the right dose of medicine. Like, he's got lots of things to worry about other than his diabetes is extremely poorly controlled. So he has other things that are threatening his survival and his good health. Yeah, and he's I think he has a long history of reading people really well and being able to say the right thing.
Yeah.
And be open and vulnerable in just the right ways that leave him not open and vulnerable. He can cry. Mm-hmm. Very interesting guy.
Very.
Mm-hmm. Yeah. So the places where you expect the sort of walls to be, no walls there, really open, maybe even lack of boundaries, but he's got his own walled off pockets that are really troubling for us, I think.
It's almost like there is zero reward to him in taking care of himself that he can sense, or to showing up to appointments. Like you had talked about contingency, as a question mark.
Which
There's nothing in that he sees, like everything that's rewarding to him is outside of the clinic, outside of treatment, outside of, right?
I did set him up for the We Connect program, where you get rewards based on like checking into appointments, and he frequently misses appointments because I can track like his progress on the screen, or he just doesn't put them in. When he does, I've been having to log a lot of them for him, like, because now we can like send the appointments to the website to him.
Okay.
But like the one that he did do was go to the movies. So at least, I mean, he did something self-care wise, but before that, it was a lot of it like hang out with my grandkids. Just really him babysitting. Which is great if that actually brings him joy, but we don't really know. Yeah. Mm-hmm. I think in the end, we feel like we really like this guy and we don't know him very well. Do you guys have any questions? You can.
Any question's a good one.
That's right. And you can also pass. Chris, what's your question?
I don't think I have a question. What was the original question? Like what we're looking for here? Remind me of that.
Behavioral health techniques to accept responsibility of recovery.
What techniques can we use?
All right, let's go to suggestions because I'm getting depressed. I'm kidding. So what kind of thoughts do you have that might be helpful for this guy? I'll say that I'm already hearing that what we already knew but hadn't been talking about too much is that we really don't know this guy all that well. Even though it feels like it, because it's always a party when he comes in, like lots of hugs and happiness and
Get that shell.
Exactly. Right. Okay. Ideas, suggestions. Oh, we got Cindy.
All right. It sounds like he will benefit from working on attachment disorder. I really don't know what the trauma is about, but definitely it has to be related to attachment. And he was described as a family-oriented and independent person. But the more I was hearing his case, I feel that there has to be other words besides those two that would describe him. Not that those don't fit who he is, but we need to get to know this client better. And I think we all agree on that. Like who you are and who you trust enough to put all those boundaries down. But definitely there's a conversation that needs to happen with the treatment provider. Once a client gives a positive, that's like a 911 conversation, especially when they're already under MAT treatment. And I remember that it was said that he's attending Mars. We do meet once a month to go over all cases. And this is a great case to talk during that monthly meeting. But once a client relapse and there's a positive, I think that the sooner we know that the client is not well, the better the outcome. We can even offer a higher level of care. Specifically, he's using fentanyl. And if he's disabled, probably he does not have an income. I don't know if he works, but let's assume he don't work. It's cheaper to buy fentanyl in the street. So he's a high risk to probably keep using an OD at some point. So I wrote something else here, which spoke about the sober time. Yes, there's incarceration there. I always see that at a conversation that needs to happen with the value. What are his values? How this trauma shape his values? So there's a lot of things that can be happening in treatment. But to answer the original question about what are the behavioral techniques, definitely reality therapy. Just talk to him about exactly what's going on. He's what, 51? What we said, 50? He's in his 50s?
52.
52, yes. I think a reality therapy is one intervention. We always use CBT, DBT, motivational interviewing, but definitely go over attachments. What is attachment? What that means to you? What is healthy attachment? How this trauma affect your ability to attach to other? How you use humor to engage with people, but you cannot internalize or even attach to another human being. And he just created this fascinating personality, but we don't even know who you are. So I think those will be 4 good behavioral techniques that can be implemented with this client.
Thank you. All right, so we have another suggestion. How about a CRS or a CCRS or a sponsor? Do we know if he's going to meetings right now?
He's not. No.
Mm-hmm.
We've tried the CRS route.
Mm-hmm. Yeah.
No.
Such a great resource, and I think would be so helpful for him. And our one limitation sometimes is that the people who need it the most are the ones who are putting up the most barriers to having that work.
When did he stop going to Mars?
He graduated, right?
Oh, says he still goes for individual counseling. Okay. I'm gonna try to probably pop up on it there.
But
yeah.
Okay. All right. Any other suggestions out there? Not currently, right? So he's been incarcerated, but he's not currently under any supervision. I do wonder how he would tell his own story. He can't yet. Okay, let's go to Yamalisa, who's chomping at the bit.
So right now it seems that he's involved with the LCSW, but it's not necessarily a true therapeutic relationship. I think it's more of a compliance of the once every other week or whatever, maybe check in. So it's going to be really important, of course, to complete that case consultation with Mars and involve his therapist there. Whether he's being seen once a week or every other week or however it may be as he's completing treatment, there are a lot of unresolved and underlying issues to his substance use. Criminality is there, of course, and the substance use, but the mental health, the trauma, and as Cindy mentioned, that broken trust from probably the childhood trauma, and then it repeated again a few years later as an adult in jail, which usually in jail we're talking either sexual or physical violent trauma. It's not anything pretty that anyone just wants to divulge, but it seems that he wants to actually address it. The fact that he opened up to you, Heather, the fact that he opened up to the LCSW, however, it may be getting said to individuals that don't have the time to sit and break it down with him. Because him sharing that with you in, you know, a half-hour check-in or with an LCSW, same thing, 15, 20-minute check-in is not going to give him enough time or them enough time to process some of that. So definitely the therapist at Mars can be an ally. However, it sounds that this individual is more going to benefit. He already has social support from family and knows how to do things. Like he can get out, he can do, he can go to the movies, he can food shop, you know what I mean? Like those things are already in place. It's more about that internal work. So having a therapist or a psychologist possibly that can truly dive in deeper and help him, you know, again, break down, kind of debulk some of that internal trauma and know the tools to be able to help him close that before he walks out of that door is going to be the best way to manage this case. Because him walking in cheerful, and again, Cindy mentioned about, you know, using humor and that mask and that, you know, pretty, colorful, I smile big and everybody loves me and my grandkids are great. Yeah, but you're also taking a risk of dying.
Multiple risks.
So, multiple, right. So, yes, you love these things, you love these people, but you don't love you. So, he just needs a more experienced, more time focused and available therapist that can work with him, it sounds like.
Yeah, I think that was probably when we started to kind of lose him a little bit, because he was working really well with Teresa. And then when she left, I think that's when things kind of, and he hasn't really built rapport with anyone since then.
And Teresa has been gone for a while, on a year now, I think.
She's out in Bill's territory now.
I know.
Yeah.
So then that's a big transition. That I'm just glad you guys still have him attending and can still help him. So he needs more of that. He doesn't need suggestions of social things because it's internal stuff.
Yeah, he's hurting all the time.
Yeah.
Thanks, Yamalisa. I wrote it all down.
Need you to take care of all the
We need her to train the next generation of Cindy and Yamalisas.
Right? Cindy Yamalisa next gen. Yep. We'll get them ready. All right, Sin? We'll get them ready.
I want to meet him now. I
know, right?
I want to meet him now.
Like, I went after the meeting. Maybe we can find out if he's actually coming. He's technically our patient, you know, at Mars, but this is all confidential.
What are your thoughts?
I'm just still wondering if there's any room for contingency management. It's a baby step. It's not an ultimate solution at all, but it sounds like, I don't know, I don't really do contingency management. I don't have a lot of experience with that. Someone who sort of sees people, apart from MAT, I see people once, you know, so I never get to, you know, but I wonder, I mean, is that ever done where you actually ask the patient what would work for them? Like, if what would be rewarding for them? I mean, it could be something that grandkids would use.
Right.
You know?
Right. So most contingency management programs have a little bit of choice, but not a whole lot. And and we've, you know, some of the good studies out there are looking at sort of raffle type models that when you come to a meeting, you can pick out of a bowl and maybe it has an affirmation that says, woohoo, you came today. But maybe you have a certificate for a VCR, or this is old studies clearly, something like that, right? Yeah, that everyone has. You can't even say you get them an iPod anymore. Anyway, so, a thing that has some value to it. It looks like sort of the sweet spot. So the contingency management idea, is that there are actual tangible rewards for participating in your recovery, and that would actually start juicing the reward system with something other than drugs, and that there's pretty good evidence that it's actually quite helpful. And those old studies talk about a sweet spot of being about $100 per thing, that if it's too little, it doesn't really do much. So we found that with one of our guys, like a chocolate bar was really right on, and he's, so you never know.
A handful of chocolate.
Yeah.
He's not engaging in the app?
He is, so he's not really doing it. So I think, so what's interesting is that for patients who have gateway anywhere in our region, and Bill, I think are you still in the Lehigh Cap region, or are you in a different Medicaid region? Maybe our Magellan folks can answer that. Can't hear you though.
We're in a different region.
You're in a different region.
Yeah.
In our region, at least for our gateway patients, if they're gateway Medicaid, not the Medicare assured, but the regular Medicaid, they've contracted with a contingency management program called WeConnect that has an app that you can load in things that you're doing to support your recovery, and you can cash those in for gift cards. They send them to you, right? They have a card that they load up, or how does that work?
They email you the gift card code.
Like WeConnect Recovery, right?
Yeah, not just plain WeConnect, because that's something else. But turns out to be toys of versions that you shouldn't see. Yeah.
Yeah, so last week he only completed 1 of 4.
Right. So all the evidence would suggest that this could be a really helpful thing, but for him, that's not how he's motivated. So, so it might be worth having a session with him to just sort of look and see, is there anything in there that would actually get him excited? And I don't know what that looks like, whether the WeConnect people do that, or you do that, or what exactly, but yeah. So that's a great suggestion. Like we actually have contingency management for him. Who knew? But
maybe like Jillian said, it may be doing things like for him as an adult, when in reality what he more needs is something that he can enjoy with his grandbabies. You know what I mean? Take him to a Crayola factory, or again, like watch a movie, or go to Dorney, or something different.
Yeah, so the motivational interviewing, that's a great suggestion, Julia. It's the sort of key to everything, right? Like, and we have discovered that we don't really know this guy all that well, giving him some space to tell us what matters to him. Over time, maybe he'll take that opportunity, right? So far, he's really good at supplying us what he thinks we want to know. And that's been a real barrier.
That's survival, though. That was learned very, very, very early on.
He's really good at it.
I can hear that. Yes.
Yeah. Other suggestions? Back out here. All right, thank you, Rosemary. And we are just about out of time, but this is has been a really helpful case for thinking about some very common issues with people with substance use disorders and trauma. How do we get to know somebody? How do we find what makes them tick? And how do we get that common ground so that we can move forward? How do you make sure you have the right resources in the right place with the team? So thank you. Thank you all. Don't forget, in the invitation, and if you guys can share it amongst the Magellan crew, there is a survey. We really want to hear from you. We have not been getting a lot of surveys back. Puppy dog eyes. Please fill out your surveys so that we can get better. We have one more session for this round of the ECHO, and then we would like to get some feedback so that we can think about what to do for a next round. I think some of the clear themes that will emerge for that is that we need to do some recruiting to get a more diverse group participating. We've had some great folks dropping in and out, but we need some more primary care. We need more nursing. We need more behavioral health because we don't have that. But put on your thinking caps, and that's a great question. He's a pretty sophisticated version of 11. The question is, he's been using since he's 11. Do you see him as an emotional age 11? That's an interesting question. I'm imagining that there are parts of him that are at an 11-ish stage, and there are parts of him who are really sophisticated and grown up, and there's not a simple answer to that. But possibly, if I'm thinking like my friend Cindy, maybe his attachment style is somewhere around 11. Mm-hmm.
You know, who's appropriate to invite, and she'd be happy to.
Oh, yeah. Anyone who's, we would love to see people, and maybe for our new session, but our goal is to help weave the connections in our communities between all the different players who interact with the patients that we're talking about. So whether we're talking about physicians, either in primary care or in the sort of emergency first responder zone, our behavioral health friends, more drug and alcohol friends, community resources. It'd be very interesting if we had some of the criminal justice people involved to sort of broaden out the perspectives on what can be helpful. And my real goal next time, most of the cases you may have noticed have come from NHCLV. I'd love to get cases coming from outside of NHCLV so that we can really start thinking about how do we help each other and how do we reduce barriers to real interdisciplinary care for our patients in our community. Invite anyone and let Star know.
Yes, please have them register.
Okay. So next session is July 9th. It will be our 12th and final session. We'll be talking about some special populations, the elderly, pregnant women. So should be a really interesting session. We'll be looking for cases. So anybody that has a case with someone who's over the ages, I have to say, we're counting anyone over age 50. So anyone my age or up counts as elderly, or pregnant women, or any other case that you want some help with. Let Jasmine know, and she'll help put it in a format that's a presentation for us. All right.
Thank you.
Thank you all.
Thank you, everyone.
Have a beautiful week.
Done out of here.
I won't have a time sheet.
That's what I gotta dart out.
Oh, okay. Andrew will be here. Okay.
There's one more session?
For this round. And then I think, team, that we should take a little bit of a break and reconvene and think about what we need to do. One of the goals that I have for when we start back up is to have NHCLV apply to the state to be a